Hi, good evening, everyone, and thank you for joining our Artificial Intelligence in Radiation Oncology webinar this evening. My name is Trina Behani. I'm staff for the American College of Radiology and KAROS. This webinar is brought to you tonight by KAROS and the Commission on Radiation Oncology. A couple of housekeeping items before we get started tonight. We will start with Dr. Thompson giving his presentation for the first 40 to 45 minutes of this webinar, and we'll be taking questions at the end. If you'd like to ask a question, there is a question panel and you can enter that in to be sent and submitted, and we will address those in the order they're received at the end of the call. Everybody is muted during the duration of the call and will remain that way for the entire webinar. So I would like to introduce now Megan McComber, who is our resident and fellow section representative for radiation oncology, serving on the ACR's RFS and on the Commission on Radiation Oncology, as well as the KAROS Executive Committee. Megan has done a great job of organizing tonight's session, and I will turn it over her tonight to introduce our presenter.
Great. Thank you so much for the introduction. I'm really excited about this timely topic, and we'll have a great speaker tonight. So tonight we will be hearing from Dr. Reid Thompson, who is Assistant Professor in the Department of Radiation Medicine at Oregon Health and Science University. He has a joint appointment in computational biology. He has a special interest in artificial intelligence topics and how these can specifically be applied to our fields. We've heard some recommendations to have him as a speaker, and so we're really excited to have him tonight. And he'll be speaking on artificial intelligence in radiation oncology. So thank you so much.
Awesome. Thank you so much, Megan. Thank you so much, Trina. It's a pleasure to be here with you guys this evening, at least virtually. Calling in from Portland, and I'm sure everyone's dotted around the country. So sorry if it's East Coast out there, but we'll hopefully keep this interesting. So again, thank you for the introduction. I'm just going to go into the talk. Most of the housekeeping has already been done by Trina, but a quick thank you to Megan again, and also to KAROS and the ACR Commission on Radiation Oncology. You know, you've heard my affiliations already. One to note as well is that I'm appointed at the VA Portland healthcare system, and I don't have any conflicts of interest, but of note for this particular talk is a disclosure that I'm on the ACRA advisory board and also the chair of the Data Science Institute Oncology Subspecialty Panel. We'll talk more about those later. If you don't know what those are, that's fine. So this is the outline of my talk. I want to make sure that I give at least a brief primer on machine learning, deep learning, and AI, presuming that no one on the panel or no one on the call necessarily has to have a background in any of these topics, but I want to at least get us up to speed. And then I want to go briefly into big data in healthcare, and specifically the ACR's efforts through the Data Science Institute, and then touch upon AI and radiation oncology, where we are and where we're going from here. So this is just a wiki page about machine learning, but briefly, it's a field of computer science that uses statistical techniques to give computer systems the ability to learn with data without being explicitly programmed. And the last point is really the key point, right? These are algorithms that essentially know what they're supposed to do to train on data, but no one is actually pulling all of the levers up front to actually analyze a given data set. And so to the right here in the slide, you see a very simple classifier, which is a support vector machine. It's just one type of machine learning approaches, but essentially the concept here is to separate two collections of points, one white and one black, on two different axes here with a line. And the idea behind the support vector machine is to try to find the optimal line that'll maximally find the spread between the points. So looking at the furthest width between these two, where you have an edge case of the black here and the edge cases of these two white points here. And so that is probably one of the most simple approaches in the field, but there are many, many, and we'll go into just a few. There are cases, for instance, where it's very difficult to split points with a single line. So on the top left panel here, you're looking at red and blue points, and I'm actually going to change to laser pointer here so it's a little more visible. And if you draw a line or an optimal line to fit these points, you can see that you're never going to be able to perfectly separate the reds from the blues because there's reds that dip down next to the blues here. Okay, well, you can draw a more complicated line or a curve to do a better job of separating, and for the most part, you get a better precision with this type of approach, excuse me. You get better precision with this type of approach, but you also still see that there are some outlying points where you have a red underneath the curve here that matches with the blues or is grouped with the blues in both sides here. And you have some blues that are still mapped with the reds. And you say, well, can we do even better? Can we fit a higher order function of some sort to be able to do a better job of identifying the blue and the red points? And of course, you could draw some crazy squiggle where you have dips down to get this red point here and this blue point here, and ultimately do a very good job of separating the reds from the blues. The problem here, as you could see here, is that there's what we call overfitting, meaning that you're training very well on the data that you're seeing. But then the question is, when you apply this approach, this model, to data that you haven't yet seen, how is it going to perform? And this is where you have error on training data. And I'm not going to describe the graph here per se, but just note that there is kind of a sweet spot where you have decreasing error on the training data. But at some point, if you keep training to fit the training data better, then you're going to start losing performance on your testing data. And you can see as the curve ticks back up, that's your kind of predictive error on the test data. So you can use other types of approaches, and this is another machine learning approach to do classification. In this case, trying to differentiate between a sick or a healthy person. Here again, you see just point clouds, and this is an abstraction of real-world data, but essentially the greens in this case would be healthy, and the reds would be sick. And you could see kind of an etch-a-sketch like distinguishing or classification between these two groups. And that etch-a-sketch is essentially a graphical depiction of the decision tree decisions that are being made on different bounds. So right at x2 being less than 0.53, that's this line here. You make one decision that you're going towards the sick direction versus healthy direction. And so you could see kind of like a Plinko board or whatever, you could end up finding where through this algorithm you are in terms of health versus sickness. Okay. Deep learning is another kind of class of approaches, and in this case, demonstrating something like a convolutional neural network, where you're taking as input a number, in this case, 7. This is a binary depiction, a binary matrix depiction of a graphical picture of a 7. You can kind of see it shaded in here. And that can be boxed up into different quadrants, and ultimately, that's fed into this complicated-looking pipe of a model where at the tail end, you see output here of different digits, 0 through 9. And so essentially what this algorithm can train itself to do is recognize an optical character, in this case, again, a 7, and output theoretically the right number. And again, not talking about the details of this framework, but understand that this is a different approach than the other machine learning approaches that I mentioned. So you could apply this to obviously some real world things. And so if you look at images here, this is a convolutional network applied to distinguishing dogs and cats. You actually get not just the difference between a dog and a cat, but actually you can distinguish maybe this is a bird or a boat. Obviously in this case it's a dog, in this case it's a cat, and it gives you some degree of a probabilistic certainty around whether it believes that this dog is a dog or this picture is a cat. And all these predictions can be done as part of the exact same convolutional neural network. But that's classification, so we've talked about that. There's other layers of complexity of problems, for instance, localization. So in this case, yeah, we know this picture is a cat, but where is the cat within the picture? And so this red box here indicates that the cat is right in the middle. You could also do object detection where you're not necessarily looking for a single cat, but you want to find multiple places of interest in a given picture. And you can see here kind of a classification in multiple areas where you see dogs, ducks, cats, etc. And in fact, you can get a more nuanced localization of objects through what we call segmentation. In radiation oncology, obviously, you should be very familiar with the concept of segmentation. You may call it contouring as well, but ultimately, you're drawing the bounds around some volume of interest. And in this case, they're dogs and cats still. And so that's another layer of complexity to actually an algorithm. When you think about AI, and you probably heard a lot about this type of stuff in the real world media, and maybe even taken a self-driving car, which would be awesome. I've not done that yet. But ultimately, this is a whole layer of complexity beyond the types of models that I just discussed, in part because this is real time, meaning these types of computations need to be made in a split second. But moreover, this is actually a compound of many, many different types of algorithms that are all pooled together. So in this case, you could see kind of at a much more complicated level, a classification task where you see these yellow cars, they're boxed out here. So this is at object finding. But beyond object finding, you're also doing object tracking and even wayfinding while the car is doing this. There's a whole lot that all gets pulled together, and this is where things become more kind of the artificial intelligence. So again, the designations, there is difference between all of them. People tend to use these words interchangeably, but you can see that there are orders of magnitude more complexity here. So that's a very, very quick primer on ML, DL, AI, and I want to talk now about kind of applications in healthcare and what is the ACR's vision here. So it should come as no surprise that there's been a lot of growth of big data in healthcare, certainly a lot of talk about it as well. This comes from our move to EHR systems with increased adoption. The kind of estimate is that there'll be about 95% EHR around the country by 2020. And certainly there's increased data quantity and complexity that accompanies this. Medical images are associated with about 70% of all diagnoses and 10% of all patient encounters, and certainly in radiation oncology, it's not quite 100% of every patient encounter we see, but certainly many, many patients have imaging data associated. There are various healthcare apps as well. MoleMapper is one example that's homegrown here to HSU. The Internet of Things, various other healthcare monitors and devices, and of course, genomics and personalized medicine. There's a large growth in sequencing data, and all of these have high levels of data streams that are ripe for mining in terms of various approaches. So lots of existing and emerging tools accordingly, many different key stakeholders here that you can think of, and obviously a lot of interest and hype around this topic, but this comes with many caveats as we'll go into some of them here. I think one of the key ones I want to highlight for this evening is that there's a significant disconnect, and maybe this should come as no surprise to anyone, but there's a disconnect between the clinic and kind of machine learning or data analytical capabilities. So this is exemplified as the AI experts don't really have the medical domain expertise, and on the converse, right, the data itself is often inaccessible to medically tuned researchers. So there are systematic challenges at all levels. This is kind of where the ACR actually comes in terms of the launch of the Data Science Institute. And the goal here is a fewfold. It's to define appropriate medical imaging AI use cases, to set standards for medical imaging AI interoperability, to test and evaluate medical imaging AI algorithms, and ultimately to address the regulatory, legal, and complex ethical issues that accompany medical imaging AI. Strategic plan, this is kind of circa July of this past year. And this is only an excerpt of the strategic plan, but there's some key points. One is obviously around patient safety. We want to make sure we're doing all this appropriately. To establish trust and an interface with both the government regulators and industry and patients. To increase professionals' relevance to patients and health systems, and ultimately around education as well, to not only train the next generation of physicians and physician scientists, but the population as well. So this is obviously not a one person or even a small team effort. This is very big topic for many different individuals and organizations. From a radiation oncology perspective, you'll see some familiar logos and names here, the APM, Arrow, Astro, etc. And I expect that this list will grow many times over the coming years. So around this whole use case thing, I mentioned it very briefly before, but the idea here is to define strategic questions or strategic clinical cases or categories to really leverage the clinical value and the technical expertise and get both sides of the equation talking to each other. This is the framework around the ACR's subspecialty panels for developing use cases. There's 10 different domains. You can see breast imaging, neuroimaging, abdominal imaging, et cetera. And of course, of interest to many on this call is the oncology, radiation oncology, and cancer subspecialty panel, of which I'm the chair. The panel is composed of about 5 other individuals who have various different expertises, both in radiation oncology, and medical physics. And again, each of these groups is working independently to identify use cases of most potential clinical impact and technical feasibility in each of these different spaces. So there's obviously many complex facets to a use case. If you think about a question, there's many people that question can affect, from patients to researchers to the hospitals, admins, payers. There's population health, implications for everything here. So not going into the details per se of each of these individual categories for the moment, but suffice it to say that these types of questions can really change the way that we practice and may change the face of what we're doing in years to come. So here's one just small example, and really this is only an excerpt of a sample use case, but you can think about this as a pretty straightforward one: colon polyp detection, right? Where you have an imaging study from a colonoscopy, and here's the various criteria for who might actually qualify for this algorithm to run, and there's technical specifications. And ultimately, there's a stated output, which is going to be, in this case, the presence of a polyp that's at least 1 centimeter large, and where is that polyp located, which of course is a different topic than just the classification or the identification of a polyp, but really kind of gets to the segmentation or, again, the object localization. And obviously, any data set should account for much variance. Maybe the images will look significantly different for a man versus a woman, or someone who is in their 60s versus someone who is in their 30s. So once these use cases become a little bit more mature, and that's certainly the plan over the coming months and years, it's going to then become time to actually do something with them, right? To bring this data to bear for the technical community to be able to develop algorithms that actually satisfy these use cases. And so MACAI is one organization that is deeply committed to this space and has partnered recently with the ACR's DSI to actually guide this type of approach, and even to sponsor challenges, which is one of the main things that MACAI does, to basically take data sets with training information and testing information and make these available to the community to actually do algorithm development. So this is pretty cool stuff, and this is coming soon to a clinic or to a computer or whatever near you. Of course, once you have actually a use case that's developed and people have made algorithms for these various use cases, you still need to make sure that there's quality assessment and really a framework to govern, or to at least figure out to what extent this algorithm may actually work in an unseen data set, right? So verification, certification, whatever you want to call it. And there's many different complexities to how to do this. I'm not going to go into those details at the moment, but obviously, depending upon the use case, would very much guide how the certification is done. And there's obviously a complexity surrounding this in terms of how to deal with the data transfer and the diversity of that data as well, different scanners, different geography, patients, et cetera, et cetera. So there's a lot that goes into this, but I think the concept should be fairly straightforward. So I want to now talk a little bit more, or focus a little bit more about AI and radiation oncology. I'll touch upon some topics of where we are and maybe speculate a little bit about where we're going from here. So again, should come as no surprise to people on this call that radiation oncology has a lot of data. CT SIM is part of the lingua franca of our specialty, and this generates, of course, lots of data in the form of 3D anatomical imaging. But there's more than that in radiation oncology as well. We have 4D respiratory gating scans. There's multimodality imaging that we often use for patient treatments, MRI, PET CT, et cetera. And even during a patient's treatment, we acquire more scans and more pictures that may be used for treatment decisions, and certainly are part of the growing data sets. This, of course, does not even talk about all of the clinical data, et cetera, that is certainly part of the whole picture. Along with that growing data sets and the quote unquote big data that's available to our specialty, there's also a growing interest in big data, and more recently even being able to leverage this big data in using artificial intelligence approaches. So example, at least two here, are just recent kind of national level workshops that are highlighting big data and AI as issues. This is the big data workshop from 2015 at the NCI, and this is the inaugural APM Practical Big Data Workshop in Ann Arbor, which is being hosted again this year. Very exciting. Certainly, I think there's growing interest again in all of these topics, but again, this means a lot of different things to a lot of different people. So how is AI being used in radiation oncology? This is some basic machine learning applications to date. This is an example applied to radiation pneumonitis using a decision tree. We talked briefly about decision trees before. That was kind of the etch-a-sketch looking picture about how to segment two different populations. And radiation pneumonitis is an interesting question because there's some known risk factors, but ultimately, to date, poor predictability of who is going to get pneumonitis versus not. So you can take this kind of decision tree type of approach, and the approach taken here in this particular study was a little bit more nuanced than a simple decision tree, but we'll just show the kind of the picture, at least as the results here. And you have patients who have some pneumonitis, plenty with no pneumonitis, and you can go through this kind of decision tree based on lung dose, tracheal bronchial dose, heart dose, and even ethnicity to improve your risk stratification of who you might believe or who you predict would get pneumonitis or not. So at the top level decision here, right, if the lung dose is less than 700 centigrade, then the risk of you having pneumonitis is, at least based on the training data in this set, virtually nil. And of course, these types of approaches can be scaled to many different other clinically related questions. Decision support can happen at all levels. So this is looking at kind of decision support at the dosimetric level, thinking about the trade-offs between chest wall and heart doses by looking at comparable patients. So if you have a patient in front of you and you have a pool of historical data, you can actually use machine learning approaches to not only identify the most similar plans or potential plans, but actually then start thinking about the ranges of observed doses in these plans, and on the fly developing kind of an understanding about the dosimetric trade-offs. This can allow you to do modality selection and ultimately to be able to guide kind of the parameters of your plan optimizations. Radiomics is certainly a topic probably many of you have heard of. I'm not going to go into all the details for sure of radiomics here. And again, it's a term that means a few different things to a few different people, but there's machine learning and deep learning approaches both in radiation oncology in the context of radiomics. So briefly, here's just a collection of lung nodules or lung cancers, lung images that are segmented out here by volume. You see they all look very different. Various features, these are engineered features, can be extracted. This is kind of the machine learning approach, where you have these engineered features that you're going to then run some classifier. So here's the radiomics features in some matrix, and you could then predict whether or not you're going to have some sort of bad clinical outcome. In this case, actually using this type of feature, you can actually predict for survival, or you could even predict kind of at a gene expression level whether basically getting at the concept of being understand biology just from an image alone. Again, there's a lot of caveats to this, but there's some exciting stuff in the field around this space. And of course, if you apply a deep learning approach, you don't even necessarily need to look at features that have been engineered. You could kind of look at the basic images themselves and have the algorithm kind of learn its own patterns. Deep learning also has applications in radiation oncology. I think probably on the top of most people's minds, you'd think the segmentation, so auto-segmentation, contouring. In this case, this is a deep learning application applied to lung imaging, and here is segmentation through manual contour shown in red. I guess you can see the outlines here. The atlas-based contour, which is in blue, and then a deep learning-based contour, which is shown in yellow. So certainly for the lung, the deep learning contour does significantly better than the atlas-based contour. And similarly for the esophagus, the deep learning contour gets things much more appropriately based on what you do manually versus kind of an atlas-based contour, which has something smack dab in the middle of the aorta. And then of course for the heart here, you see that, well, the deep learning approach actually doesn't do quite as well as you would expect. In fact, the atlas contour does a little bit better, but fundamentally, we're applying these things to date. This is actually just a relatively recent study. We are starting to apply these types of approaches and algorithms in at least research-based settings, maybe not in actual clinical care. The deep learning, similarly for auto-segmentation, this is actually a schematic from another company. No names on companies at this point, but this is kind of a depiction of the framework around a cloud-based deep learning approach where the acquired imaging data can leave the institution, go to the cloud, and the algorithms can actually be applied to then do the segmentation, return those contours back to the clinic, and those can then be used. And actually, this has been shown to be an effective way of scaling. And there's some good reasons to think this is good, and some reasons to think this is also challenging. Ultimately, the implementation completely depends upon the circumstance. So there's no one size fits all here, and this is not necessarily the be all and end all approach to how this should be done. But again, there's growing interest around deep learning and radiation oncology. Certainly, I think most lowest hanging fruit would be in the auto segmentation space. There are lots of challenges, and I could have rattled off a list of other types of artificial intelligence approaches, whether it's machine learning or deep learning in the radiation oncology space. But I want to now talk a little bit about the kind of the caveats here. So this is by no means a complete list, but I already mentioned this before, and I want to highlight this again. There really is a mismatch between the necessary technical and clinical proficiencies in this space. We also have a data problem in that multiple systems are not reliably integrated, and certainly the data on those systems is not reliably comparable among institutions. All of these algorithms to date certainly need expert oversight, and often intervention is required. And even with, say, perfect training data, that's the case. But often we're looking at imperfect training data, meaning that there's inter-observer variability among contours. So if you ask 3 different clinicians to draw an esophagus or to draw some volume of interest, whether it's target volume or otherwise, you'll get slightly different contours. And the question there is, of course, well, what is the algorithm training to if already there's human variability? So there's also a limit in terms of the training data sets. It's very easy to put, or more straightforward, I should say, to put together a single institution training data set to kind of start asking questions, but that's a rare institution that has the size of the data set to really be able to leverage appropriately. So it becomes a challenge of quantity of data. And then there's also less generalizability. So even those institutions that have a lot of data that they're sitting on, they're not necessarily, their patterns of care, the patients they're seeing, the way that everything happens in that particular clinical setting may be very different than the way that someone else may practice, whether it's in the community or a separate academic center, or in another country, frankly. So really, without looking at data sets across institutions, there's really less generalizability. And by generalizability, I mean the ability to apply the learned model or the algorithm from one place successfully in another place. And ultimately, extrapolation is extremely, or at least can be extremely dangerous. And of course, a challenge or a field overall is just we're relatively small fish in a relatively big pond. That doesn't mean we lack the passion or the capabilities. I'm just saying we're small. So where are we going from here? Well, obviously the future is notoriously difficult to predict. I'm not going to actually pull a crystal ball on you guys here, but there are many opportunities and competing forces at play. And I'll probably touch a little bit more upon those broad concepts. So first, in terms of guiding kind of the way that one might envision all of this playing out, there's this technology acceptance model. It's been around for quite a while, and really it's in its simplest form, thinking about, is the technology useful, right? If it's useful, that's generally a good thing. People will tend to want to use it. And the other thing is perceived ease of use. Well, it might be useful, but people might think it's really hard or it's hard to access, et cetera. So that's the perceived kind of ease of use side of things. And both of those are critical for something to be accepted. But so long as it's useful and easy to use, this is a compelling step forward in terms of the technology being accepted. And of course, there's lots of different factors, and this is a schematic that really is very, very chunky in its framework, but really is very, very broadly extensible. I added this whole box here of cost because I think, yeah, something can be perfect and wonderful and easy to use, but could also cost an exorbitant amount of money, and in a resource-limited setting, it may or may not apply. It may or not be implemented, even if it's great. Let's see. Okay, so hopefully we have learned by now some of the lessons of IMRT in terms of how things roll out in terms of new technologies. I would anticipate that in the AI space, when we're applying new algorithms, for instance, segmentation being, again, some low-hanging fruit, that we'll have, or we should see, more serial prospective technology assessment trials. And so actually this is an example of one that was performed a few years ago, looking at just an auto-segmentation. And the approach that was used was kind of a blinding and looking at kind of resident modified contours versus manual segmentation. So looking at the differences of volumetric agreement. This is DSC, dissimilarity coefficient. It's a volumetric assessment measurement. And I'm not going to go through all the numbers here, but basically these were the results as a per volume of interest assessment. But there was actually a concerted clinical study to try to do this prospectively. And I think we'll see more and more of these types of things, or at least I hope we see more and more of these types of things as various approaches roll out. Another concept I think that we're going to see, certainly it's been much talked about over recent years, but there's still a lot of challenges to these implementations nonetheless. As I mentioned before about the availability of data and the importance of having interinstitutional data and large data sets, this concept of federated data is likely to see more traction. So on the left, this is kind of the standard approach where we have institutional data is acquired and you have raw data that's pooled, and then you have knowledge bases that are acquired. This can happen in parallel at multiple different institutions to do lots of different types of questions, personalizing treatment, rare tumor cases, comparative analyses, whatever have you. But towards the right here are different kind of schematics of how to integrate these types of data from multiple different institutions. So you could have a centralized approach where you have centralized database that everyone feeds into with learning on top of that database. You could have a decentralized approach where everyone is kind of having their own database and learning happily on this database, but the results of these are being interchanged freely among institutions such that all institutions are learning from each other, even as the data sits in one place or is in separate places. And there's, of course, hybrid approaches where the data can move between places and some third-party centralized processing. There's no one way to necessarily do this, and every application may have its own pros and cons in terms of what types of approaches and frameworks to use. But again, I think we're going to see more and more efforts to do this type of thing, about sharing data across institutions, making data more public, etc. I think we'll also need to see accordingly multiple partnerships among various stakeholders. There's certainly academic collaborations which happen to date, and even community academic partnerships and community partnerships, but there's other things like government level interfaces that this type of stuff is going to need to have support from. And there's examples here in terms of expedited frameworks for software as medical device consideration, and public engagement is going to be necessary to really leverage technological expertise that's way beyond the capacity of our specialty to sustain or to maintain or to grow. There's a lot of hobbyists and other professionals and industries that are starting around AI, and things like a Kaggle challenge or the Mackay challenge that I mentioned, or other types of approaches of bringing this data to bear for people who may be able to develop technologies is, I think, something we'll be seeing more of. At least I hope we will. And I also think that in all of this, we need to make sure we always have caution or the patient's best interests in mind. And I think the priority needs to be safety first. We will most certainly see false starts along the way. I think it's likely, at least, but we'll see to what extent this happens. And along the lines of prioritizing safety, we're going to need to make sure that we have QA frameworks on top of both developing and deployed algorithms. So, right, you may need to actually start doing QA on the software as it's running. There's also the important concept of AI interpretability. A lot of these times, these algorithms will spit out some magic number or some magic result, but you're not really looking at the internal workings of how that all happens. And frankly, you don't want to look at all of the math. But that said, if you have no understanding of how it happens, there's really then the question of, if you get some aberrant result, is it accurate? How do I trust this? So this opens up a whole topic of conversation of complexity. And so one real aspect to promoting this all is really to make sure that the AI itself is interpretable and visible. And there's going to need to be expanded safety frameworks. So there's things like the Radiation Oncology Incident Learning System that exists currently, but these types of things are going to need to be scoped for accommodating manifold new type of safety potential compromise. And I think overall, the caveats here are to always maintain constant vigilance. So there's going to be, no matter how good the AI might get at some point, we're going to need to maintain some sort of clinical oversight to make sure that we're always putting the patient first, and that ultimately there's some degree of sanity check on things. Okay, I'd like to summarize briefly, and again, this is by no means a summary of the entire talk or even any of the topics necessarily that I've discussed, but I think I want to leave you with these thoughts of pitfalls and potential of AI in radiation oncology. So to the pitfalls side of things, there really are a million questions that you can ask and answer using this type of approach, but really not all of them are clinically relevant or necessarily clinically feasible. It's going to take a lot of work to really identify and prioritize questions. And again, this is part of what the DSI's use case panels, the subspecialty panels are all about. Another pitfall of AI is really the concept of non-reproducible results or out-of-sample invalidation. Again, how does something that has worked in a testing and training and all the sandbox that you've had it in setting, but now it's in the real world, it's going to another institution, maybe it's going somewhere internationally, how does this actually maintain its validity? And it really is a significant pitfall and concern. And the other thing that I've not touched upon really here, but it's about the point of care integration of how do you actually bring all this stuff to bear and being able to have it leverage in a sufficient timeline and in a clinical workflow to benefit the patient. And with that said, I like this cartoon. It's, this guy sitting here, I'm worried that healthcare has become too impersonal, doc, and he's got a barcode on his back. I mean, it's definitely something that we may be in danger of in the future. Certainly, there's already this type of thing as we need to interface with an EMR. But of course, there's a lot of potential here, and these are only, again, a very tiny tip of the iceberg. There are emerging tools to accelerate learning. Things like Google TensorFlow is one example of being able to put very, very complex and powerful tools at your disposal, even if you're not someone who necessarily is able to develop the complex matrix, mathematics that may need to happen for a next generation technique of whatever sort have you. So this is really a way to use out-of-the-box approaches. There's also, I think, really a growing excitement around large-scale collaborations and potentially even international efforts. I think Europe is a little bit ahead of the curve of us in this regard overall, just by nature of geography and whatnot. But I would also say that this is of growing interest. I know that the ACR through the DSI is certainly engaged with international stakeholders as well. So this is something I think that is very exciting, but we need to all keep in mind to make sure that everything is maximally effective. I really do believe I've drunk the Kool-Aid to some degree, although I still remain a skeptic, but there is really transformative potential here in terms of clinical value of being able to accelerate care, to actually deliver the types of care that we're not actually feasibly able to deliver to date, and hopefully transform health and maybe cost. With that, I'll say thank you again to all of the attendees. I hope I didn't speed along too fast, and I again appreciate your time. I'm happy to take questions. And just one thing before I do, just a note here, there's a web link on the bottom of this slide. And this is actually, I hope it's still live. I didn't check it right before this talk, but basically it's an input field for if you have an idea around a possible use case. This is a way to submit this to the DSI, and the use case panels will be processing these various suggestions, and hopefully you can actually nominate kind of the next use case. So with that, again, I'll say thank you very much.
All right. Thank you, Dr. Thompson, for that excellent presentation. This is Trina, again, from the ACR staff. If you have a question that you'd like to ask, please enter that using the question panel. I will start with a comment, I think, in follow-up submitted by one of our participants, George Hanna, who says a practical solution would be to utilize this in the vendor realm to aid them in coming up with libraries which they check and then distribute across departments. This would increase uniformity and reduce the QA load of constantly reinventing the wheel for each case and would reduce system resources at each center. I don't know if you'd want to comment on that
Yeah,
comment, Dr. Thompson.
that's certainly an important concept overall, right? The ability, how can we minimize distributed QA and really make sure that we've maximized vendor level or algorithm level assessment of an implementation. And certainly there is a lot of effort and investment to work at the vendor level and essentially make sure things are FDA approved for clinical use, et cetera, at the governmental level in that sense to approve the algorithm. However, keep in mind that as new data is fed, algorithms can evolve. So there may actually be some migration of an algorithm depending upon how it's used in the clinic. There's also issues of how an algorithm can be used, period, right? You may apply the wrong algorithm to the wrong setting, thinking that it's the right thing to do, and you get input, or rather output, that seems intelligible, but really is based upon a completely arbitrary model that's not applicable to that given case. So I'm not saying that that's going to happen frequently, but these types of things are going to need to be QA'd as well. So I think we're not going to be able to completely offload QA of algorithms and implementations at an institutional level. But I agree, we really do need to think about how to minimize these types of burdens.
Okay. And another comment that came in says, I believe that QA needs to be done at both places, departments and vendors. Ultimately, it's the responsibility of the department that deploys algorithms to QA them.
So I agree, obviously.
So another question here from Dr. Seth Rosenthal. First, he says, thanks to Dr. Thompson for an excellent presentation. As radiation oncologists, we are very focused on issues of quality and safety. As a specialty, we experienced some unexpected quality and safety issues 1 to 2 decades ago associated with the rollout of IMRT. What potential pitfalls may exist with AI, and what can we do as a specialty to anticipate them? And what QI initiatives do we need to prepare to be able to address these issues?
So Seth, thanks for that. This is, of course, a very important thing, and I don't want to necessarily suggest things that are going to stymie progress, but frankly, I think we did learn a lot of lessons with IMRT, and I agree that there needs to be a similar framework, or not a similar framework, there needs to be a framework around the rollout of various algorithms to actually make sure that this is done appropriately, but again, not trying to actually propose obstacles to technology development. So what kinds of things? Well, I alluded already to this being done in the form of prospective trials. Certainly, if an algorithm is released, it also needs to be stress tested, and that doesn't necessarily need to happen at a validation level, although it should happen at a validation level. I think we need to think about how to stress test these types of algorithms. And by stress test, what I mean is, challenging things with wacky anatomy, challenging things with absolutely improper cases, right? So if you're looking at some sort of prostate contouring thing, throw in a thoracic volume, right? Like that kind of stuff. It would be an example of a stress test. You'll get arbitrary weird output, but these types of things need to be carefully done. There needs to be some sort of framework around algorithms to better understand how they're working. This is a really, really complicated topic that's, I think, going to have groups of people working around how to do this in terms of standardization and governance structures. So I don't want to comment further as I have a prone to start rambling. So I will just say that, Seth, you're absolutely right. I don't really have a laundry list here of recommendations, but I think these are critically important, and I do anticipate that we're going to need a very concrete framework around algorithm rollout, AI rollout specifically, that we didn't have during the IMRT era to prevent types of harms that could happen.
Okay. Another both comment and question coming in from Arthur Hung. It says, great job, Reid. One of my concerns about developing big data tools is that we become so focused on the result, but have very little information about the data going in. Examples I can think of using the MSKCC nomograms for prostate cancer or their circulator, where patients and providers give an outsized emphasis on the number put out by the tool. Are there any efforts to give us a snapshot of the quality of the data?
Yeah, so this is great, I think ultimately that's something that is really an interesting topic. The quality of the data is going to be really, the algorithm rather, the quality of the algorithm is going to be only so good as the quality of the data, garbage in, garbage out, right? So presumably you're going to have some level of trust that the training sets have been sufficiently well thought out. They'll reflect the actual real world implementation that you're seeing in your clinic, but you may have a wacky patient population compared to what the algorithm has been trained on, and it may not perform well in all settings. So even if you have great confidence in the actual algorithm itself, how it performs in a real world setting in your specific institution really is actually a hard thing to assess. Because you may be dealing with edge cases that are really underrepresented in the data set that was trained. So I actually think that this is something that probably needs to be made transparent around the various algorithms to explain how these have been trained. Of course, you're not going to be able to then look at this data set and somehow intuit whether it applies to the clinic that you're carrying. So it may still, even if it's transparent, it won't be necessarily human interpretable. So I think ultimately this is where the stress testing and that kind of thing is really important to make sure that these algorithms have some real ability to be generalizable. The other thing around just kind of nomograms are a very easy example of a model that's just applied to data, and that could be just as easily a machine learning approach. I think the implementation of machine learning output could be very similar to nomograms, but Art, your point is right. Maybe this needs to be a little bit better in terms of how it's integrated into the clinic. And this gets at a whole another topic of conversation around the actual point of care. And I'd hope that we'll do a better job of being able to understand and interpret the actual rationale of why a model is actually saying what it's saying, rather than just giving output.
Okay, at this point, I don't see any additional questions coming in. If anyone has any, please, again, reminder, just use that question panel to input those.
I'll say one other thing if I can, Trina, if there's no questions. Yep. I didn't touch upon kind of the educational aspects of this, or residency or training or fellowships or anything along those lines. And there's plenty of other topics we could have talked about as well. I wanted to make sure that this was a relatively small package. There's a lot of stuff in there. But I will just comment and say that that's an unaddressed area in this talk as well. And I think that there's going to need to be a specialty-wide commitment to training. I think we'll probably see a growing interest among trainees overall in these types of approaches, even before they're completely mature. So I hope that as specialty, we'll be recommitting and doubling down on actual training platforms and opportunities for residents, fellows, etc.
Great. Well, I have not seen any additional questions come in. Looks like you've addressed everything that our participants have had. So I'd like to again thank everyone for joining us tonight, those who logged in, and thank you again, Dr. Thompson, for taking time to make such an excellent presentation. Thank you to KAROS and the Commission on Radiation Oncology for supporting and encouraging this, and to Megan McComber for her work in getting things set up and extending this invitation. So with that, we'll close out this evening. This recording will be posted online and made available. If there are additional questions that individuals have after the fact, feel free to submit those, and we'll pass those along to Dr. Thompson, and hopefully we can maybe carry this conversation on our Engage platform provided by ACR. So thank you again, and good night, everyone.
Thank you.